If you've ever thought, my AMH is high, my embryos are going to be great quality, or you've thought, my AMH is low, I am doomed and I'm not going to make any good embryos, this video is for you. There is a brand new, very large IVF study talking about AMH and antral follicle count and whether or not it predicts embryo quality. Today, we will review this latest research and what it means for you. I'm Dr. Lora Shahine, a double board certified OBGYN and reproductive endocrinologist, helping people build families and do IVF for almost 20 years. If this is your first time finding the channel, welcome. I'm so glad you're here. Subscribe so you get all of my educational videos. And if you're coming back because you found this content helpful and valuable, welcome back. I am so glad you are here. There are two other ways to stay in touch and learn more and more about reproductive health. Number one, you can sign up for my newsletter. It's in the description below. And number two, you can listen to my Brave and Curious podcast out wherever you listen to podcasts, diving into reproductive education and health and beyond. Now, today we are talking all about common tests, AMH and antral follicle count, that are often done with fertility evaluation and specifically done before IVF, and what these outcomes, these measurements mean for embryo euploidy. Euploidy is whether or not chromosomes are balanced in the embryo. It's if you do that testing, that PGTA testing, pre-implantation genetic testing for aneuploidy, the AMH and antral follicle count can often be used to counsel how likely or not someone's going to get euploid or chromosomally balanced embryos. And this brand new study that came out recently really helps us understand exactly what AMH, antral follicle count, and what this could mean for counseling. Today, we're going to cover four main topics. Topic number one, we'll do a recap of AMH, antral follicle count, what they are, what they mean, and a review of IVF and PGTA. Topic number two, we're going to review this recent study, exactly how it was done, who was included, and what they were trying to answer. Topic number three, we're going to go over the results of the study and what they actually found. And topic number four, we'll do some insights. I'll give you some takeaways, and stick around to the end of the video. I'll give you three important questions to ask your doctor before you do IVF. Topic number one, recap and review. Before you do IVF, you will often get a lot of tests done. Two of the most common tests that are done are AMH and antral follicle count. AMH stands for Anti-Müllerian Hormone, and it's a hormone that's produced by cells in the ovaries surrounding eggs. The higher the AMH, the more supporting cells and the more eggs you have in your reserve, or the eggs that are up for grabs and recruitable for an IVF cycle. So a high AMH could mean that you could get 15, 20 or more eggs with one egg retrieval, and a low AMH could mean that you could get less than 5. AMH is a quantitative test, and it's a blood test. Now, antral follicle count is quantitative as well, but it's a little bit subjective because you are counting the number of resting antral follicles on the ovaries while you're looking at them with a pelvic ultrasound. So you do an ultrasound. It's a really common part of a first fertility evaluation. You're looking at the shape of the uterus, you're looking at the ovaries, you're looking for fibroids, you're looking for ovarian cysts, and then in a fertility clinic, they're going to do an antral follicle count, and you're counting these little dark circles in the ovaries. I say the ovaries look like chocolate chips. I say the ovaries look like chocolate chip cookies, and the antral follicles are the little chocolate chips, and you count them up. The more resting antral follicles, likely the more eggs you could get with an IVF egg retrieval cycle. And the lower number of eggs that you see, typically the fewer eggs you're going to get. Before we had AMH, all we really had when I was practicing, more than 10 years ago, 15 years ago, all we had is an antral follicle count. And it was helpful, it's quantitative, but it is not as predictive as AMH. But both of these measures are now typically done in most clinics before IVF begins. Now, reminder, IVF, in vitro fertilization, this is a process of stimulating the ovaries in order to recruit multiple eggs and retrieve the eggs from that ovaries to fertilize with sperm in the lab, watch the embryos grow. And then Not everyone does PGTA testing, but before you would freeze an embryo, you can biopsy cells away from the embryo and send them to a specialty lab to do specialty genetic testing. The most common type of genetic testing that is done on embryos is PGTA, pre-implantation genetic testing for aneuploidy. Aneuploidy means abnormal chromosome balance. Euploidy means balanced chromosomes. So remember, every time an egg and sperm come together, they each give half of the genetic content, and they give it in the form of chromosomes. Remember those X's in biology class? One copy of that X comes, or the chromosome comes from the egg and one comes from the sperm, and they come together. In every cell in our body, we have 23 pairs of chromosomes. Again, half came from the egg and half came from the sperm. If at fertilization, whether it's in the body or in the IVF lab, the egg and sperm can get it right or wrong. And if you hang on to too many chromosomes, that is typically called triploidy, like 3 copies of number 7 chromosome. Or if you're missing a chromosome, that's typically called monosomy, like monosomy 20. Then the embryo can look beautiful under the microscope. It can even divide and sometimes even implant, but it will typically end in a first trimester miscarriage. So aneuploid embryos either will not implant or typically will result in a first trimester miscarriage, but not result in a live birth. And one of the most amazing inventions or advancements in IVF in my career is seeing how great the PGTA testing has gotten, how accurate it's gotten, what it can pick up on, the type of testing, and how they can see so many different things within chromosomes. And it has dramatically changed IVF. The success rates have increased, and really importantly, there is no reason to transfer more than one tested embryo. The reason we used to transfer 4 or 5 embryos to someone was because we know as eggs and sperm age, more and more of the embryos have genetic mistakes, and it takes more embryos to have a baby, especially as you get closer to 40 or over 40. Now, if you can screen embryos outside of the body before you implant them, you can transfer 1 embryo in a 42-year-old and still have an excellent chance of live birth without taking the risk of twins, triplets, or more. I have so much educational content on my YouTube channel on IVF, PGTA, genetic screening of embryos, timeline, medication, side effects, lots and lots of education and information. I also have a lot of information on age and fertility, because that is really important to understand not only the age of the egg, but also the age of the sperm. So the question we're really trying to answer in this video and from this study that I'm going to present to you next is, does the testing before you start IVF in AMH and antral follicle count really predict if you're going to get euploid or chromosomally balanced embryos? That's what we're going to review next. Topic number 2, let me tell you all about this study. The lead author is Eubanks. Title of this study, Beyond Numbers, Anti-Müllerian Hormone and Antral Follicle Count are not independent predictors of embryo, euploidy, and IVF with PGTA. Well, there you go. I answered the question. In the title, it's right there, but I want to explain more. Let me tell you more about the study. The objective of the study is clear. It's in the title: to see whether AMH and antral follicle count are associated with embryo euploidy rates in IVF with pre-implantation genetic testing for aneuploidy, independent of maternal age and other confounders. Confounders are things that could sway the results that you're looking for, and you use mathematical models to try to isolate those things away to see if the association still exists. Translation: if 2 people are the same age, does the one with the higher antral follicle count and higher AMH have a higher chance of getting euploid embryos? That's the question. Study design. This was a retrospective cohort study using data from a large U.S. fertility network. It included 11,473 women and over 13,000 IVF cycles. All cycles used autologous eggs, so this is not donor egg cycles, and PGTA testing with next generation sequencing. Data collection occurred from October 2016 through August 2024. AMH and antral follicle count were measured within 6 months of the egg retrieval. The authors analyzed euploidy rate as the primary outcome, but also looked at implantation rate, clinical pregnancy rate, and live birth after transfer of a euploid embryo. They grouped AMH and antral follicle count in 3 separate groups, sort of like low, medium, high, with the Bologna criteria. For AMH, low was considered less than 1.1 nanograms per ml. Medium was 1.1 to 4.0 nanograms per ml. And high was 4.0 nanograms per milliliter or higher. Antral follicle count, low was less than 7. Normal or medium is 7 to 16, and over 16 or 16 or more, it was considered high antral follicle count. They also analyzed the data in quartiles and treated AMH and the antral follicle count as continuous variables, plus additional modeling to check for nonlinear threshold effects. Let's talk about what they adjusted for. Crucially, they adjusted for maternal age and polycystic ovarian syndrome diagnosis. People with PCOS often have a very high AMH and a very high antral follicle count. And in some models, they adjusted for BMI or body mass index and accounted for the fact that some patients did multiple treatment cycles. Topic number 3, what did the study find? Here's the headline. Euploidy rates were basically the same across AMH levels and antral follicle count. Let me tell you more. So AMH categories and euploidy rates. If the AMH was low, less than 1.1, 56.9% of the embryos were euploid. If the AMH was in the middle between 1.1 and 4.0, and euploidy rates were 54%. And if the AMH was considered high, over 4, the euploidy rates were 55.8%. So not clinically significant based on the AMH levels. Pretty much in the 55% range euploidy, regardless of AMH level. How about antral follicle count? Honestly, similar. So antral follicle count, low, less than 7, euploidy rate 56.3%, antral follicle count in the middle range, 7 to 16, 54.8% euploidy rate, and antral follicle count over 16 or high, euploidy rate 54.9%. So even when adjusted for statistics, any differences were very, very small and not clinically significant. And this did not show the pattern that people assume. People assume that even if you're older in age, as long as you've got great ovarian reserve, you're going to get higher percentage of euploidy. They also looked at outcomes, and AMH levels and antral follicle counts were not clinically associated significantly with live birth, clinical pregnancy, or implantation rates. So this means once you have a euploid embryo to transfer, regardless of your AMH or your antral follicle count, you have a very similar live birth rate. The authors point out clearly in their conclusion and the discussion of this excellent article that age is still the most important predictor of euploidy in embryos. As eggs and sperm, but in this paper they're really talking about eggs, age, more and more of the eggs make mistakes. Remember, those eggs are in our body since we are born, and it's when we ovulate, whether we're 25 or 45, that the eggs get turned back on. They get rid of half of their genetic content. So the chromosomes are sitting like this with the chromosomes that came from the egg and sperm that we came from. They're sitting like this until we ovulate. And when we ovulate, the eggs get turned back on. They finish meiosis 1. They get rid of one of those copies of chromosomes in order to be ready to fertilize with the sperm. And the sperm comes along and gives its copy of the chromosome. And sperm have an age impact. I've got a whole video here on the importance of paternal age and success with fertility and treatment and outcomes. Sperm age matter, but it's not as dramatic and it doesn't happen as early as with eggs. So guys make sperm every single day, and when they're made, they're ready to go. So the sperm aren't sitting in the body, with 2 chromosomes, just waiting to ovulate. It is a little bit different. As sperm age, there's more new mutations that happen in the sperm, and counts go down, motility goes down, fertility declines, but that really doesn't start until late 40s, early 50s. And really, just for this particular video and this particular study, they're really focused on eggs. So what is this study telling us? AMH and antral follicle count are valuable markers of ovarian reserve, or the number of eggs that are up for grabs and able to be recruited in the IVF stimulation cycle. So this is quantity. But AMH and antral follicle count have very limited ability to predict quality or chromosome content in embryos. So this study is really helping us realize that AMH and antral follicle count shouldn't be used to try to predict the chance of a euploid embryo. So despite some smaller studies that might say differently, this large analysis does not support using AMH and antral follicle count as standalone predictors of embryo euploidy. Topic number 4, what should you take away from this video? I've got 5 takeaways. Takeaway number 1, don't use AMH as a quality score. A high AMH can predict likely more eggs retrieved and probably more embryos created, but it does not mean each embryo is likely to be euploid. So don't let a high AMH give you false reassurance about the results of your PGTA testing. Takeaway number 2, a low AMH does not mean bad eggs. If you're younger and your AMH is low, yes, you might get fewer eggs with each egg retrieval. You might have fewer embryos to test, but you still have a very high chance of getting euploid embryos based on age. It might take more egg retrievals, but remember, AMH is quantity, not quality. Takeaway number 3, use AMH and antral follicle count as setting expectations or thinking about strategy as you're getting ready to start IVF, but not predicting chromosome euploidy. So again, if you have a low AMH, it might take more egg retrievals to meet your family goals. If you have a high AMH, it might take fewer egg retrievals. AMH and antral follicle count are still incredibly useful in 4 ways. Number 1, estimate the response to stimulation. Number 2, counsel you on the number of eggs to expect from each retrieval. Number 3, planning dose of the medication and counseling people on the risk of over-response or ovarian hyperstimulation syndrome. And number 4, discussing whether or not you might need more than 1 egg retrieval to meet your goal. Takeaway number 4, counseling can sound a little bit something like this. Your AMH is high, and it suggests that we're going to get more eggs and likely more embryos to test. But AMH doesn't tell us whether or not these embryos are going to be euploid. That I would help you guess based on age. Your age is still the strongest predictor of euploidy or chromosome content and balance within the embryo. And if you have diminished ovarian reserve, we really have to look at strategy and setting expectations on the number of egg retrievals it may take to meet your goals. Takeaway number 5, what this means before committing to IVF. If you're deciding whether or not to do IVF, use the data that you have to have a thorough discussion with your doctor about setting expectations. Use age, AMH, and antral follicle counts to help you understand how many egg retrievals it may take to meet your family goals. I'm so glad you stuck around to the end of the video. I want to give you 3 important questions to ask your doctor. Number 1, based on my age, my antral follicle count, and my AMH, how many eggs should I expect? How many embryos will that likely result in? And how many can I expect to be euploid? Question number 2, if my AMH and antral follicle count are high or low, how would that set my expectations for embryo quality? And finally, question number 3, if I get a euploid embryo, what are the chances of live birth with that transfer? So if you have gotten your AMH and antral follicle count results from your clinic and you are spiraling, take a deep breath. This is 2 pieces of the puzzle, and it's not the end of your story. And you've got to talk to your doctor to go over your entire picture and your personal situation to understand what your AMH and your antral follicle count mean for your IVF journey. I hope you found this information valuable. Like this video if you learned something, comment with questions that you have. Be sure and subscribe to this channel so you get my weekly videos all about reproductive health. And until next week, stay brave and curious.